Hello, everyone. My name is Kasey Roberts, and I'm the first-year fellow at the University Hospital's Metro Health Urogynecology program. Today, I will be presenting my research project titled Major Adverse Cardiovascular and Cerebrovascular Events Associated with Female Pelvic Reconstructive Surgery. I have no disclosures. American women carry an estimated 20% lifetime risk of undergoing procedures for pelvic floor disorders, or PFD, and most of these procedures are performed on elderly patients during their 7th decade of life. Major adverse cardiovascular and cerebrovascular events, which will be referred to as MACE for the remainder of this presentation, represent an important group of adverse postoperative cardiovascular events which have been studied in multiple surgical populations. MACE includes myocardial infarction, abbreviated to MI, cardiovascular arrest, abbreviated to CA, acute ischemic stroke, abbreviated to AIS, and all-cause mortality, abbreviated to ACM. Currently, a contemporary understanding of the risk factors and incidence of MACE in the pelvic floor disorder population remains limited. Because of this, our objective was to look at women undergoing surgery for pelvic floor disorders and first evaluate the incidence of MACE in aggregate and then by type, and secondly, to evaluate the risk factors for MACE. Here are the what, how, when, and where of this project. This is a retrospective cohort study using the National Inpatient Sample, or NIS, over the years of 2012 to 2016 at the national level. The inclusion criteria are listed here and consist of patients older than 18 years who had a primary admitting diagnosis of pelvic organ prolapse and who had a procedure code for obliterative or apical suspension procedures. The exclusion criteria include patients with a primary diagnosis of malignancy of female genitalia and their associated procedures, those patients with a comorbidity that occurred in 1% or less of the total population studied, and records with incomplete procedure, diagnosis, or charge data. For the incidence objective, we used ICD-9 and ICD-10 codes to identify those patients who suffered from MI, CA, and AIS, and we determined ACM by counting the number of patient charts that indicated that the patient was deceased. For the risk factor objective, we collected information on additional variables that we felt might represent risk factors for MACE, then stratified patients into those who did and did not experience MACE. From there, we compared the frequency of each variable in those who suffered from MACE compared to those who did not suffer from MACE using Student's t-test or Fisher's exact test as appropriate. Finally, we used multivariable logistic regression to determine which of those variables represented independent risk factors for MACE. Here's a table that lists the variables that we looked at to determine if there was an association with MACE. For our statistical analysis, we set our significance at a level of p is less than 0.05. Here are our results. We found 53,540 patients who met both the inclusion and exclusion criteria for our study. Of this approximately 50,000 patients, 256, or 0.47%, were found to suffer from MACE. The breakdown of the various types of MACE is presented here. MI was the most common manifestation of MACE, with 196 subjects, or 76.6% of all MACE being attributed to MI. This is followed by AIS at 13.3%, then CA at 9%, then ACM at 7.4%. These are the results of our risk factor objective. The yellow highlights indicate those risk factors which were found to be associated with MACE. For the purposes of keeping time, I will only present those variables which were found to be associated with MACE on logistic regression analysis. Increasing age was found to be independently associated with MACE, while no region of the United States was found to be independently associated with MACE. Nor was any median household income found to be independently associated with MACE. Nor was any type of insurance found to be independently associated with MACE. As far as cardiovascular risk factors go, only congestive heart failure was found to be independently associated with MACE. In regards to pulmonary and hematologic disorders, only coagulopathy was found to be independently associated with MACE. Of the other medical risk factors evaluated, only a history of neurologic disorders and electrolyte abnormalities were found to be independently associated with MACE. We evaluated for an association between primary surgeries and surgical complications and MACE. On multivariable regression analysis, only blood transfusion was associated with MACE. Finally, we evaluated for an association between concomitant surgery performed and MACE. However, none of these concomitant procedures were found to be independently associated with MACE. So for our discussion and recap, using the NIS database from the years 2012 to 2016, we identified approximately 50,000 patients who underwent surgery for pelvic organ prolapse. Of those 50,000 patients, 256, or 0.047%, developed MACE. Myocardial infarction was the most common manifestation, and all-cause mortality was the least common manifestation. On multivariable regression analysis, we found certain variables to be independently associated with MACE. These variables are listed here in order of most associated to least associated. Coagulopathy was most associated with MACE at an adjusted odds ratio of 5.53, while increasing age was found to be least associated with MACE at an adjusted odds ratio of 1.04. There are a couple of study findings that we would like to point out. The first is that our rate of MACE was only 0.47%. When compared to similar studies which also evaluated the rate of MACE in patients undergoing non-cardiac surgery, this rate of MACE is considerably lower. As you can see, other similar studies found MACE rates of 4.3% and 4.5%, which is almost a tenfold increase from our rate. We feel that there are several reasons that this may be the case. One possible explanation is due to the much smaller sample sizes of these studies, which may have artificially increased their MACE rates. Our study has the advantage of using a nationwide database that is able to sample a large heterogeneous population and as such be more reflective of reality. However, another important difference between our study and others in the literature is the patient population. In these two studies, which found MACE rates in the 4% range, they say that they recruited patients undergoing both scheduled or emergency surgery, whereas our study was only evaluating women undergoing surgery for pelvic organ prolapse. Given that pelvic organ prolapse is almost never an emergency, our patient population would have had time to be medically optimized prior to surgery compared with the patient population of the other studies. We believe that this is the most likely reason that our rate of MACE is so much lower than the rate reported in similar studies. I would also like to point out that while there are several variables that were found to be independently associated with MACE, type of surgical procedure was not one of those variables. This is a surprising finding to us and one that we believe may be able to be at least partially explained by trends in current surgical practice. Here is a study which looked at practice patterns and surgeries for pelvic organ prolapse over a 3-year time span from 2010 to 2013. Note that the number of inpatient procedures decreased over the study time period, while the number of outpatient procedures increased. This indicates that procedures that were at one time considered to be exclusively inpatient procedures have now started to become offered as outpatient procedures for a variety of reasons, including an increase in the number of minimally invasive modalities, and that there are some patients who have been deemed healthy enough to tolerate an invasive procedure on an outpatient basis. Because we only evaluated inpatients, there is therefore an inherent bias to our study population. Instead of comparing all women who underwent surgery for prolapse, we compared patients who were kept inpatient postoperatively because of poor baseline health status or increased surgical complexity. For example, a patient with a history of congestive heart failure and 2 prior C-sections undergoing uterosacral ligament suspension, against those patients who underwent procedures that have maintained their inpatient status regardless of patient baseline health status or surgical complexity, such as abdominal sacrocolpopexy. We suggest that despite our multivariable analysis, an unintentional selection bias in imbalanced groups may have prevented us from discovering an association of MACE with procedure type. The strengths of our study include its large sample size and that our data was obtained from a national database that utilizes a standard method of data collection as representative of 20% of cases performed in the United States, which allows estimates to be made about the actual incidence of the disease process in the US. Limitations include that there is no standardized definition for MACE, which makes it difficult to perform reliable comparisons between our study and the existing literature. As a generalization, our study evaluated fewer manifestations of MACE compared to similar studies and may therefore underestimate actual incidences. In conclusion, although MACE after surgery for pelvic floor disorders is rare, it is nonetheless a serious, life-threatening event, and further research is needed to develop specific interventions targeting the independent risk factors for MACE in patients undergoing surgery for pelvic floor disorders. Here are my references. Thank you for listening, and to all of my mentors who helped me with this project.